Thank you so much for joining us today. We are getting down to the last two sessions before our summer break for this group, and we are always excited to have you all join. Please introduce yourself in the chat, who you are and which institution you are joining from, any news that you have related to adaptations or not. Please feel free to put in the chat so we can share it with each other. And I am going to introduce our speaker today, and then I'm also going to go through a few logistical slides and then hand it over to her for the main event for today. And then, as I mentioned, today we are going to have a presentation. June, we have wonderful plans. And then we are going to take a summer break for July and August, returning in September with an unusual date. So I will point that out. So let me start actually here. So our June meeting, we have Mr. Bob Ramadan Kirunda, who is a very frequent member, visiting member of this group, who has been joining us for most of our meetings over the past year or so. And he will be talking about adapting an evidence-based model to traditional cultural systems without losing fidelity, early lessons from the planning process of scaling real fudders in Uganda. So we are very excited to learn from him. And then again, there is the break. And then in September, we are starting back strong. We are moving our meeting 1 week back due to another conflicting event, but we will be meeting at the same time as usual in terms of the hours, but it's going to be September 16th, and it's going to be Dr. Julia Moore from Canada. She will be talking about the Map to Adapt, which is a free interactive tool. We are looking for presenters for October and November. And then December, we have our usual event of Russ or myself, or both of us, talking about the D&I conference as a wrap-up. And then we close the year. So again, there are openings for October, November, and next year. Please send us any recommendations, or if you would like to present, we would love to know that. And Kara is providing here both links and QR codes for you to access it. And then the soonest event that is coming up that is kind of related to our group here is the Colorado Pragmatic Research Conference, or COPRICON. The 2024 event is fully virtual, and you can still register. It is going to happen June 5 and 6, and there are some really great keynote speakers and others. I don't know, Russ, if you wanted to add anything else.
The only thing that I'll add is I'm sure many of the talks will be addressing context and adaptation, and there is a one specific panel solely on adaptations. So if you look at the agenda, you can see that. But I think that'll be really relevant, and a specific part of that panel is being sure we save plenty of time for audience interaction and participation. So
that's fantastic. Thank you so much. And I think that also in terms of publications, if you have a publication related to adaptation, send it to us, because Kara puts together a really good newsletter, which we really appreciate. And we can highlight publications in that as well. We have not requested it from you, but we would love to see any presentation, publication, etc. So with that, we can go to either the previous or the next slide. No, wonderful. So thank you so much. I am very honored to introduce my wonderful colleague, Monica Perez-Yales. She is an associate professor at the Department of Pediatrics at the University of Colorado, the School of Medicine, and also a key faculty in our Adult and Child Center for Outcomes Research and Delivery Science at the University of Colorado in the Implementation Science Core program. And her work is really, when I think about it, and I'm going completely off script now, because I kind of know what Monica is working on, and she's going to share about it. But there are two topics that immediately come to mind for me, and that's really simplifying her portfolio. But I think that helps me think about her as a wonderful collaborator. Health equity and engagement of partners from different backgrounds, but especially those who have not been engaged or given voice. And so all the ideas around co-creation and thinking about how to bring people together in a meaningful way, and how to, again, give voice to those who are not usually involved in decisions. And then on the other side, which is a little bit more on the methods and also contributing to this co-creation work, thinking about functions and forms. And I have to admit that, my current work is really building on Monica's prior work on thinking about how we distinguish functions and forms in interventions and implementation strategies. And she has not only published and led the publication of the key publication around this function and form, but also is developing this area further and has now tools and other things available. So we are very lucky to have her present to us today. And of course, using these methodologies, she does a number of different topic areas and populations. And so she will share about that. Monica, we are so grateful to have you. I know that you are very busy. And so for you to come is really wonderful. I will hand this over to you. And please share additional things about yourself that you feel would be important for the audience to know.
Wonderful. Good morning. I'm always so delighted to be in this group. I need to keep coming back. Thank you, Borshika, for such a glowing introduction. Very kind of you. And definitely, I am very excited to share our latest work with Ross and Meredith Forth on thinking conceptually, but also striving to apply it. It's always the balance, right? And conceptually, how do we do things in a different way, but also, okay, how do we apply it? Exactly how do we do that? This presentation is based on our latest publication on how do we apply a framework with an emphasis on equity, an emphasis on acknowledging the dynamic systems, context, local context, and how do we do this? Who can we engage with to do this? So I'm going to share our efforts. It's a work in progress in this front using PRISM and RE-AIM. And as you mentioned, yes, I truly believe that we can address health equity from a team-based science approach and implementation. D&I, our field, is so promising to help us deliver those solutions in a way that matters and that are relevant and applicable for the communities we care about. And I am including the concepts of functions and forms as part of acknowledging local context and how to align the implementation of our solutions to those local contexts. All right. So it's around 10 my time, Mountain Time. I think the idea is the presentation for the whole session, Borshika. I should have asked, but I didn't. Do Monica, I have...
we need at the end about 2 minutes just to thank you mainly for your presentation, and it would be wonderful to have discussion. So we usually ask you to, present up to 10:45 your time or before, and then open it up for discussion. If you would like to have more discussion, we always welcome that. There are usually many, many questions.
So we're on the same page. Yes. All right. So I put together some slides. Let me share my screen. Yeah, I think it's this one. Hope you can. Okay, can you see the slide?
Yes, that's great.
All right. Well, let's get started. See if I can work on moving them. I wanted to acknowledge that this is not just my work, but the work of our team, our colleagues, and building on each other's efforts, as in my view, should be part of team-based science, including those that you see there. Here is, as I mentioned, a plan for our conversation today. A little bit of introduction in terms of local environments, but I'm gonna dive deeper into how do we apply a context-based framework such as PRISM that includes RE-AIM from these three core areas, or with a focus on those 3 areas. And I'm going to share a pilot project that we are working on with highlights on how we're striving to apply these areas and a few home take messages. All right, let me go this way. So let me get started by talking about context. I know I'm preaching to the choir, but in terms of, we're here in this group because we value the role of context and our need to tailor and adapt. So as I mentioned, it matters and it has an impact in local communities, in our systems of communities that we're working with to deliver our solutions. So A little bit in terms of aligning intervention to local context. Why? Because of course they can impact the implementation process, even the intervention itself before, during, and after. Another point that I like to highlight is that context reflect the diversity, rich diversity, and reflects the goals, the resources, and the values of local communities. So that's another key reason why we pay so much attention to the local tailoring of our interventions. We know that context matters, and in our field, we have a plenty menu of theories, models, and frameworks, including the website that Borshika, Meredith Ford, and others have been working on. So we have many options in our field. I'm going to share with all of you one such option that we have been working on with our colleagues at a course in our program. And one is, of course, PRISM. It stands for Practical, Robust Implementation and Sustainability Model, or PRISM. I really like this approach. Why? Because it's context-based. It's a context-based implementation science framework. Has been used in many ways, has been around for a while. The developer, of course, is here with us. So it has been used for evaluation, for implementation, as a determinant, as a process framework, and it incorporates RE-AIM. So we wanted to address that. The PRISM and RE-AIM are one approach, and doesn't mean that you cannot use other type of outcomes, but we incorporate RE-AIM as part of PRISM in an aligned way, and that will be my approach for this presentation. Again, you don't have to use necessarily RE-AIM when you are using PRISM, but we offer it as an aligned full package, so to speak. RE-AIM, I hope that everyone is familiar with RE-AIM or have heard of it in this group. If not, I have included the amazing publications and citations at the bottom at the website. But RE-AIM is an outcomes implementation framework, and it helps us really translate research to practice and policy with real-world applications. And it's comprised of 5 key outcomes, as you may know: reach, effectiveness, adoption, implementation, and maintenance. And again, RE-AIM is also incredibly helpful because it includes individual level factors as well as multi-level setting factors. And we wanted to stress the importance that the impact ultimately it really relies on us considering the interaction of these 5 outcomes together. Quite often they are not used all 5 together, and we should report why we're not using them together, but we really stress that interaction among all these 5 outcomes. So with a little bit of very short background on that, I really want to move us forward on our current efforts to offer our lessons learned and guidance on how to apply this framework, PRISM and RE-AIM, from these 3 focus areas: equity, diverse and dynamic systems, and from a co-creation engagement focus. And I have included some publications there at the bottom that are really, really new: 22, 23, and 24. The first one is already available if you don't have it. Okay, so let's start by asking this question, if we may. How do we apply PRISM and RE-AIM from an equity focus? There are several ways of doing this, but one way that our team has been working on is you can dive deeper with this amazing paper from Meredith Ross and Spiro Manson. I recommend you reading it in details, provides you more diving in suggestions on how to apply PRISM and RE-AIM from an equity focus. I'm just going to highlight a few areas from this paper and from this approach. One, by saying that we do have opportunities to address equity at each stage of the RE-AIM process with each of those 5 outcomes in terms of representation and representativeness. We had a very interesting conversation about what is the difference between the two of them. Perhaps if we have time, we'd love to hear your thoughts. But we can think of each of those outcomes not only by adoption, but what is adoption in terms of representation, and is that representative of the populations we care about? So that's one of the first highlights that we wanted to share, is how do we think of those 5 outcomes from an equity perspective for all of them, not just RE-AIM. Then we wanted to present the PRISM and RE-AIM framework. There are several versions of visual versions, so you may have seen this one or others, and that is just fine. We use this one for our paper, acknowledging that it's a circular process, but just for a matter of presenting these key applications, we wanted to use this model. And you have here the PRISM that is comprised of 4 factors or contextual buckets. Frameworks help us understand phenomena through buckets, conceptual buckets, and those are multi-level or sector perspectives on the intervention, external environment, and the characteristics of our partners, including patients, implementers, as well as the capacity and infrastructure to innovate and implement and sustain innovations. Those contextual buckets then help us better understand and align how we design, test, evaluate, and implement and disseminate interventions, either your clinical intervention or your implementation strategy that often is also called an intervention. I know, gets confusing, so for now we're gonna refer to those as different names, just so we don't get confused. And how we understand local context as a way of better informing those at the middle, our interventions, to get us to those outcomes, in this case, the RE-AIM outcomes, get us to better define, collect information, interpret the data we obtain, and disseminate the impact of our interventions. So that's in a nutshell what we have here. From an equity perspective, besides really exploring the opportunities to address equity at the bottom for each of the outcomes, the paper that I just shared from my colleagues really points out to key areas, key points that can be helpful for us as we are understanding local context. For example, at the top, you can see in terms of us really thinking of historical and structural drivers of equity for the health public policy, public health topic in question that you're working on, just really thinking in context, local context, in terms of historical and structural drivers of inequities is very helpful at this point in this area of PRISM, as well as then incorporating many perspectives and many voices to really understand that history. At the level of the intervention, planning to ensure equity is addressed. So planning is so key for us to be able to acknowledge, be respectful, and address inequities, and really understand how inequities are manifesting in our local context while we are designing and evaluating our interventions and really delivering those. As well as key for this group, tailoring and adaptations are so key to address equity, health equity, and systems equities. And then at the bottom, as I mentioned, we could explore interactions among outcomes, how is RE-AIM interacting with effectiveness and with our implementation. So really explore those pathways can be very helpful. Subgroup analysis by race, ethnicity, age, or other key characteristics can be very helpful in our quantitative analysis, for example, or through qualitative interviews, digging deeper into what about RE-AIM could impact implementation, maintenance, and really looking at, you see on the right, unintended consequences. I do some research on ACEs, adverse childhood experiences or psychosocial screenings in primary care. Sounds wonderful in terms of whole person care, but there are several unintended consequences. That's part of really thinking of our impact in terms of unintended consequences linked to hopefully not perpetuating the historical and structural drivers of inequity at the top that you see in this model or visual graph of PRISM and RE-AIM. The citation again is there, lack of time to dive deeper into this approach, but I recommend you take a look at this paper as a building block for our team on the next two approaches in terms of systems and co-creation. So I'm going to move us to the next approach, thinking in terms of equity and answering this question. I'm going to move us to the following question. Okay, how do we apply a framework, context-based framework, in this case, PRISM and RE-AIM, from an equity focus, while acknowledging this rich, beautiful, dynamic, and diverse local context where our solutions are being implemented? So here is one approach, not the only one. We have many approaches to this. One approach is with our recent publication. Of course, I would love for you to read it since we have been working on this in our efforts to answer this question. So next, I wanted to acknowledge the concepts on functions and forms. They were originally coined by Penelope Hodge. She is in Australia. And with Brian Midman and Rebecca Legning-Hall, we published the JGIM paper in 2019, really taking up with these concepts, further developing these concepts in terms of definition, developing tools such as Matrix, so we can really use these concepts. They have been incredibly helpful in my career to understand, especially multi-level interventions. What are they? Core functions and forms. You may be familiar, I hope. If not, core functions think of core functions of an intervention as the structural, procedural goals or purposes of your intervention. The functions are really linked to your mechanism of change. If you do not allow for those core functions to manifest during the evaluation and testing and implementation of your intervention, we can't really say that you're going to achieve the change that you expected or the impact. So it's really critical for fidelity, for the integrity of your intervention. Forms, on the other hand, are flexible. They are a menu of how do we do this? So here are our purposes to achieve a change. How do we do that for this context with these partners? So it is meaningful and it works in local communities. As you may be familiar with the literature, multi-level interventions often has mixed results, in great part because our challenge of really acknowledging the dynamic nature of complex contexts. So these forms could be workflows, could be steps, procedures, activities, could be your implementation strategies, our strategies, a way of tailoring those core functions to local context. So again, our chances of having a successful implementation and sustainability are increased. I included a couple of suggested readings for you. So looking at these two concepts, functions and forms, as interrelated and helping us think, forms could be included with adaptations and tailoring. Functions could be related to functional fidelity. And I have seen that term from Penelope Hodge, Brian Midman, and others, including us. We go back to the same model. We talk about equity, but let's add, okay, how do we apply dynamic systems, complex systems, to also address the richness of our communities and local contexts, and interrelated to equity, acknowledging the diversity of our context. We understand local context at the top, but it's very important that we could apply functions and forms to the way we design, again, test and implement our interventions. And that means part of the planning, that means ongoing tailoring and adaptation. So these concepts could be very helpful for you at this middle point in this framework when you are working on your interventions, either your clinical public health policy intervention and or strategies, or both if you have a hybrid type of study. All right. So we are moving from equity to acknowledging the rich, diverse, dynamic context where our solutions are implemented with two concrete concepts that can be helpful to you. And where exactly, not exactly, but where could we really apply these concepts throughout this framework? Now I am moving, and I'm very mindful of the time. Okay, yeah, we're doing pretty good. We're moving to the third question. So I walk us through acknowledging or applying PRISM and RE-AIM from an equity perspective focus, while acknowledging dynamic and diverse context. Context matters. And then the last question I'm going to pose to us will be, okay, who can inform this? Who do we work with? What type of engagement could be most or quite suitable for us to do this, to tailor, to better understand local context, to align to interventions and better tailor for success and for meaningful impact in the communities we care about. We can't do this alone. We really need to do this with our partners, and that's where, as Borshika mentioned, I'm really interested on the science of engagement as PCORI. Patient-Centered Outcomes Research Institute funding agency has recently started funding projects on what they call the science of engagement. So how do we learn and approach engagement as a science, a systematic approach of how can we better learn ways to partner with our local communities, representatives or individuals, and for this case, what type of engagement would be the most suitable for us to answer these questions? Let me start before jumping to the type of engagement. Again, a little bit in terms of for our field, both fields of implementation science and health equity, we do share a most important premise, and that is understanding local communities and being responsive to their goals, their resources, and their preferences. So we do share that from both of these fields, and that means two concrete things. Many, but two of those are here. For us to consider a context-based framework, and PRISM is one of those, and actively engage diverse partners that represent those, really reflect or represent or are part of those rich, diverse communities to better understand our local context and start that process of tailoring, designing, and defining and interpreting our impact in terms of RE-AIM. Okay. I always like to define terms. If we don't define, we can't measure, and we can't measure, we can't really evaluate. So this is one definition of engagement. It's coming from PCORI. It's a little bit old, well, it's 2022, but I put stakeholders in brackets. I prefer to use partners. Amy Hodgman and other colleagues have mentioned invested partners and others. But it's really, how do we bring our partners into a more equitable engagement process where their expertise, could be lived experience or other type of experience, is equally valued and contributes equally to our research process and implementation. So it's patient-centered, relevant, and useful. Again, this is one way of defining engagement. There are many ways of defining it. And this is from PCORI. I want at this point pause and acknowledge other fields who have worked on health equity and engagement before implementation science. We should not reinvent the wheel or claim that we have invented these areas. So I really wanted to acknowledge other fields such as health equity research, global health, CBPR, health disparities research, and I put a very few citations at the bottom to acknowledge that other fields have been tackling these issues way before implementation science was even formed. But I wanted to acknowledge that we're learning from other fields as well. How can it work for our field of D&I? All right. So next, I hope I can give you a strong argument as to why an active, more level type of engagement is suitable for our often challenging task to, again, understand context, local context, inform that understanding on the way we design, we evaluate, test, and implement and disseminate interventions, and in the way we pursue knowing our impact. And one of those type of engagement is through a co-creation type of engagement. So what is co-creation? I quite often hear us researchers and others talking, we co-created this, we co-created that, and seldom or sometimes I don't see how do we define it and how do we measure it. So for now, I'm gonna stick with how do we define co-creation, and there are several ways of defining co-creation. I'm sharing 3 ways. The first 2 bullets that you see there are from adjacent fields, public engagement, civic engagement. They have been working on this with this concept from a while back. And as a way of bringing our partners to be part of setting the direction of development of something, in this case, could be research. But the direction we're now driving with our partners. Another definition that you see there is what it means for professionals to open the processes to other partners. Again, this is from public civic engagement. It could be consumers, it could be advocacy agencies. And the last one is more health related with Green Hall and others. And I really like this definition is a collaborative generation of knowledge, not only by researchers or academics, but with our partners, patients, community leaders, nonprofit organizations, policymakers, payers, for example. So again, there's no one definition of co-creation. There are several. I wanted to share that we have been tackling this question of how do we promote or foster a type of engagement with our partners that help us co-create the direction and the knowledge and how we go about this process of research and implementation. And we have a paper at the bottom is citation with some of my amazing colleagues, Katie Wolging, including, and we started with where we often start literature review. What do we know about co-creation? Based on that lead review and conversations with national teams of researchers and a community member in LA, Los Angeles, we came up with 5 principles of co-creation, and you can see them there. And when we talk about co-creation with our partners, we often saw in the lead review in terms of increasing equity in relationship building, creating spaces for reflection, foster reciprocity and mutual benefit. So it's not just the benefit to the research, but what will be the benefit for our patient and community partners to be part of this research engagement process. Promote an individual or personalized experience for all partners, and really nurture and facilitate diverse social networks. These principles keep evolving. This is a relatively new field in D&I. So we are learning a lot. Now we are currently in a PCORI-funded project, developing a measure of co-creation in research engagement with a national group of experts that are half our patients and community and patient advocacy organizations. So we're learning from their perspectives on how to better help us define co-creation in research engagement and the principles. So I'll keep you posted. Perhaps I can come back when we have the final results from this study. All right. So where is co-creation fitting within these building steps in terms of the model? So we went back and forth, where is co-creation? And we realized with our colleagues that co-creation should permeate every single step or phase in this process. We should bring our partners. Advisory boards are wonderful, and having an advising voice from our partners is wonderful. But here we're really advocating for us to bring a more co-creation type of voice with our partners so they can help us understand local context. And they are part of informing that middle area, the interventions, and they are part because they represent one of the key parts, the local context at the top, they can help us define, evaluate, even collect data and interpret outcomes. In this case, RE-AIMs. So again, co-creation type of engagement could be from your pre-exploration and pre-implementation planning phase to align community priorities, goals, needs, and resources, and incorporate this knowledge through understanding local context, then designing, the testing and delivering interventions, and then really how we come about of learning of impact and how do we disseminate our results. Very few minutes on how are we striving to apply that. This is a pilot project using a co-creation workshops to design and integrate a screening tool for new patients of cancer. And for sure, I'm gonna call it the IAC3 tool. And you can see some colleagues who are part of this project. This IAC3 is part of, we're building on My Own Health Report, which is an online screening tool asking patients questions about their lifestyle, and that it includes social needs, social and physical needs. This pilot is using co-creation engagement strategies to incorporate diverse perspectives from clinical partners and patients to better understanding the context of oncology clinics when they start developing treatment plans with new patients. How do we understand that context, and how do we incorporate the knowledge into the design and adaptation of the AIC3 tool that is started from the My Own Health Report? Here are 3 or 4 concrete, hopefully, examples for this pilot on how we are addressing. In this case, some of the PRISM contextual domains. I don't have time to really dwell on each, but some areas, how we are understanding the organizational perspectives by including clinical partners from multiple roles, including management with a steering committee, but also frontline work navigators, patient navigators, schedulers, coordinators. We're including patient perspectives at the point of the tool design before we even have funding to test it. But the early planning and design of the tool included those clinical partners and patient perspectives. And how do we better understand the capacity and infrastructure of the external environment while acknowledging inequities is by really incorporating local resources by zip code, for example, on transportation as part of the tool. So if we ask if you need transportation, the tool should find ways to refer patients to local resources in their communities and know where they are, even when there are very few resources. How do we use the concepts of functions and forms? We use workshops with clinic personnel and partners, and we presented the table. Of course, we didn't say functions and forms. That's very jargony. But we presented this table and asked them, here's what we want to do. This is an idea of this screening tool, and these are the goals. I use that word goals. I know it doesn't encapsulate, really reflects core functions, but it's an easy short word to share with our partners rather than core functions or a long definition. But we say, here are the purposes. Are we on the right track? Are we missing any key goals for this screening tool? And this is how we're planning on making it work. What are we missing, for example? But we started there working on this table in terms of functions and forms with our partners this early on. A little bit of the timing, how we started this pilot project. During the exploration phase, planning phase, and implementation and sustainment. Exploration phase was even pre-funding period. We built the knowledge to design and really think of the functions and forms of this AIC3 screening tool and engage our partners this early on. Then we moved to pilot testing, where we developed this pilot screening tool with this knowledge, and we did some user testing design in English, and we are planning on starting workshop sessions in Spanish. And then that is leading us to seeking R01 funding, for example, or formal funding through the National Cancer Institute for us to just scale up our early knowledge. So we really work on the early phases to better understand local context and better inform the design of this screening tool, AIC3. Very briefly, in terms of RE-AIM outcomes, we have been during our team meetings, have been working a lot on thinking, who are we missing at the table? Who needs to be included in the design? So that's why included, we're planning for Spanish-speaking workshops, for example. I'm just gonna stop there in terms of highlights. Okay, a few home take messages. The first one is, this is work in progress. We don't have all the solutions, the answers, excuse me, but we're striving to be very mindful and concrete on how do we apply it conceptually, and then at the same time, in our projects, start thinking, applying, working on those applications and documenting. And we have several ways of documenting that I could share later on at another opportunity. So the first one is, as we know, diverse contexts are dynamic, and they are impacted by historical and structural inequities, but they can be modified. It's not easy, but that can be a goal of our project, to acknowledge them and find ways to address them. They are modifiable, and there is hope to change those factors. PRISM is an evolving model, and it can really help us focus our attention on key issues related to implementation, equitable outcomes, and sustainment, as well as aligning, tailoring to context and adaptations. We are advocating for us to consider aligning the type of engagement that is suitable for these goals. These are not easy goals, and a type of engagement such as co-creation can be suitable and critical in our field. In terms of active engagement, can be included from early on from the planning. You could include internal pilot funding, mostly for incentives. And if you're junior faculty or academic or researcher, you can partner with a more senior academic or researcher to find ways to bring a team to implement these, for example, co-creation workshops, but early engagement, active engagement of our partner for understanding local context and then informing that middle area is critical. And the last, identifying and applying the concepts of functions and forms is one helpful way to approach our understanding and balance of the boundaries between fidelity and adaptations. And I think that's it for me. Yes.
Thank you so much, Monica. So wonderful, and a lot of progress of applications and making this very accessible. There are some questions in the chat, so I would like to start there, but I would like to encourage everyone to jump in and add additional questions in there. This is a wonderful opportunity to interact with Monica. Let me see if I can pull a few questions here. So the first one is actually, I'm going to bundle two questions, and they are a little bit tangential, but perhaps important. The idea of co-creation is the language that you are using, and I have been using in my work. There is also the terminology around co-production or co-development. Do you find it important to think about these differences, or do you kind of bundle everything under the umbrella of co-creation?
That is such a good question, and we're working to put it in writing. So how we are conceptualizing or thinking about co-creation in engagement is more of an umbrella. Is how do we bring together our voices to influence knowledge and really inform that product. It could be an intervention. It could be a concrete iPad or health product or public health campaign. So how do we co-create that knowledge in the direction of research with our partners is a focus of research, engagement process. So that is the focus of co-creation in research engagement. Co-design and co-production can be thought as concrete methodologies. For example, user-centered design uses co-design and co-production, but that's a methodology to develop a product. a methodology to develop an intervention. So we're really focusing on the, again, engagement process and how do we co-create, in this case, the direction and the building of knowledge and of that product for the partnership.
Thank you so much. That's very helpful. Kelly, would you like to just unmute yourself and ask your question?
Hi, Monica. Thank you so much for that presentation. And thank you, of course, for leading this work in our field and really pioneering the form and function concepts. They've been really helpful, I know, in my own work. I'm gonna ask you a practical, pragmatic question, and I'll tell you why I'm asking this question too. So I'm really interested when people talk about engagement and co-creation, and especially when we start having principles or standards, that we're meeting now to do things like co-creation, I'm really interested, especially when it comes to equity, and how we can make sure the people who really need to be a part of that co-creation process are there. And I'll tell you why I'm asking, part of why I'm asking this question is because in our ISC3 at Harvard in the IC program, we're doing a methods. So we had this issue over the past few years of feeling like we're not really always getting to the frontline workers, the medical assistants, the community health workers, even the people who aren't in managers or leadership roles, who are making adaptations, who really could have valuable insights into how an implementation process is going. And we've noticed it, and it's not new to just our projects. And so now we're doing this methods pilot where we're finding those people and we're asking them, like, what makes it challenging for you to participate and partner in research? What do you need? And it's not all about supported time or protected time. Often they say, like, we don't even know, we didn't realize we had expertise or that we could talk about a topic. You get this email and you're not sure, is this really for me? And it's, so we've done these focus group interviews, and we have this advisory group of colleagues in D&I science who are interested, especially in low resource healthcare settings, how we really get to engage people. So I'm just really curious your thoughts about those practical issues of really making time, finding resources, and engaging the people who are the ones we really need to be talking to and partnering with in our work.
Thank you, Kelly. Such a key question. I think it's a struggle not only an engagement in our field, but in other fields. How do we engage very busy, burnout, stretched thin partners even in research? And I will argue that we're having more of a hard time after COVID than before. I think many of you might be experiencing even hard time recruiting for research projects as participants, much more inviting partners to be part of a research project, as Kelly mentioned, focus groups, advisory board, advisory groups. So definitely quickly, I can offer some highlights. I wish I have the perfect answer. Definitely continue to assess our recruitment strategies. We have used for some of our projects reputational social network approaches, and that is coming from sociology, I believe. Katie Wilgen introduced me to this concept in terms of identifying someone, getting the buy-in of the project, and then that person identifying a key partners that are suitable, and then reaching to them with the okay of this person and building groups gradually. Ross also mentioned in the chat, starting not from scratch. We started from my own health report. How do we adapt this? So it's some knowledge, there's some structure there, so we don't start from scratch, given our tight timelines and funding. And the third point I can share, and others may have other suggestions, is starting really early. Co-creation means if we could start in the planning phase. When we asked for adaptations, and I saw a comment, could we talk about co-adaptations? Well, we were building the knowledge and direction of those adaptations. That will mean a definition of co-creation with our partners. But when we bring them to give us their advisory voice on something we're already implementing and adaptations, that is so later on the game that perhaps including them in the design and the idea in early planning phases, pre-implementation, might increase their knowledge and sense of belonging and understanding of what we're trying to do, what we're doing. Not only that, but even if we lose them along the way, our project or interventions are better informed and perhaps have better chances of making it all the way, not in 10 years, but shorter in terms of successful implementation and sustainment, because we brought our partners early on to understand environments, even before we start testing or implementing, and also better informing the design and direction of our research. That in this pilot for us has been incredibly helpful. Not perfect solutions, but it's some areas that we need to keep working on, definitely.
Yeah, I think that's good. And I think it's also important just to be flexible when it comes to defining like co-creation. It can't always be from the very beginning and through everything. And at every meeting, we have to also be really flexible with what, especially if we're talking about low resource healthcare settings, what people can give and the value and helping them feel valued. And even if it's one meeting that they can join through your whole process, but they're contributing. I think with these standards and definitions, it seems like to me, it's just really important to be willing to be flexible with them and allow people to adapt them to their context in which they're doing the research. It's great. Thank you.
I agree, Kelly. Thank you.
Super. Wonderful discussion around this. And Russ added a little bit more to that in the chat of him using the terminology of co-adaptation when we are starting not from scratch. So I love that as well. So I think that I like the idea of, using creative terms and then also defining what we mean by them in that specific study. Related to terms, Julia Moore is on, and she asked a question. I don't know, Julia, if you want to come on, and I'm looking at time, I might read it quickly. This was a fabulous presentation. The field has been using many terms lately for similar but different things, like functions, mechanisms, and purpose of implementation strategies. Could you share how you differentiate these? And you can find this, Monica, if you need to look at it. It's about six comment from the bottom.
All right. Yeah, I'm making sure I copy the chat. This Julia, great comment. Let me take a look. So it was the comment on the difference between mechanism. What else? Sorry, can you help me?
So there is the field has been. Let me just copy it also down here. But it was about terms like functions, mechanisms, purpose of the implementation strategies, which might be similar, but then also different. And I just reposted it.
Yeah, I think I saw. Thank you, Julia. We need to keep working on this. Yes, we know that in our field, we do have an issue with many terms and how to use them. So core functions, in our 2019 paper, we did include that as part of the definition, that is the purpose of the intervention. It has to do with how to achieve change. So the core functions are related to the mechanism of change, but in my view, it is not exactly the mechanism of change. There are more other things, more in terms of implementation and intervention mapping with Maria Fernandez. She expands, that's another way of really expanding the mechanism of change with determinants and other key steps on the mapping. But the core functions is kind of that guidance on, I would say, purposes of an intervention, and it could be a strategy. We do test our strategies and they are considered an intervention. So we could consider conceptualize strategies as what is the core function of this strategy? What is the purpose? Linked to a structure and procedural standards and mechanisms of change. And then what are the concrete activities of the strategies? Is it a manual? Is it a parent training? That are going to help us achieve that goal for the strategy as an intervention. Not very clear cut. I think we need to keep working on writing it down and continue to kind of flesh out these concepts and put the boundaries among them. But that would be my take in terms of functions, mechanisms, and purpose. We have used the word purpose as part of the definition of core functions. And again, in my view, and we are still early in this field, core functions are part of the mechanisms, is informing, is setting us up in that direction. But mechanisms of change are way more than just the, not just, but the core function. A mechanism of change is the whole process that includes the theories in theory form, which is incredibly necessary for defining those core functions, but also achieving change. Any others who might want to answer that question if we have time, but that could be a discussion for more than an hour. And in fact, some groups have engaged in these discussions for months.
This is
happy
super,
to
Monica,
continue.
and I think Julia is very satisfied with your answer. So I'm going to actually ask another question. It was mine, but others might be also wondering, when you are doing the function and form activities with your partners, kind of going through the matrix, identifying what forms will be appropriate, is that usually kind of a one meeting situation where you go through all of them together, or is it more of an iterative process? How much time does it take? How much time should we schedule for this?
That's a good question. And I will say what Rose often answers, it depends. I know that. I know you didn't want to hear that. It depends. So, and that goes to Kelly's point, it really is linked to the capacity of our partners' systems and even our own capacity. I have done it with FQAC system in California for 5 months, longitudinal, similar partners throughout the process on identifying the core functions, tweaking, refining them, the forms. I did use implementation mapping with Maria Fernandez for that NIMH project. For the IEC3B tool, we use interweaving, we overlap clinical partners and patient partners' voices, but not necessarily the same individuals. Again, these are new patients of diagnosis of cancer, which can be triggering. It can be traumatic for many patients. So we might have them only once, but we use these workshops because it really was hands-on. Clinical personnel we started and we got information. So we fed that into a patient workshop of 45 minutes to 90 minutes. It could be during lunch or after hours. But when you invite partners to say, we really want to co-design through user-centered design and user testing, but we really want your voice even from the beginning. They're really interested on that design phase and planning phase. And quite often I've heard, we really often don't include it at those phases. Then we learn from patients one time, 45 minutes to 90 minutes. If we add a user-centered design, user-centered testing, we create a train clear on the prototype, and then back to clinicians. So we use those sequential loops. Could be one time with the roles were the same or similar, but it could be one time with our partners. And that's very short, trying to make it brief.
Yeah, no, this was very efficient, very helpful, and definitely it depends. It sounds like you have to be thoughtful about how you do it. I wonder if you consider studying generative mechanisms, the mediators that make workshops bring about higher engagement of the engagement strategies. I'm reading it from the chat. Monica, if you would like to look at it yourself, that's going to be our last question, and we are already on the top of the hour. So if you could just provide a 3-word answer, and then we can always take it offline.
Sure, Mohammed. No pressure. 3-word answer. Engagement, cost, evaluation.
Okay.
We really need to head there and really test our types of engagement. It's a co-creation type of engagement, giving us the back for investment, as Kelly would mention at the beginning, and evaluating the value. We need to get there. We're not there yet.
Super. Thank you so much, Monica. This was more than we were hoping for, and clearly there is a great interest. Actual 3-word answer never happens. Everyone, thank you for the very active engagement. We will see you in June again. And if you have ideas for future calls, always get in touch. We love to see you. Thank you.